Now I'd like to invite Dr. Shalin Shah. He will be speaking on interpretation of imaging and relevance of orbital perfusion.
So, ma'am has given us a very comprehensive view of how to remove the tumors. Now, I'll just brush upon. Sometimes we need to look at the DICOM images ourselves and before planning the surgery. And often the diagnosis given by the radiologist is, we may differ in our clinical diagnosis as compared to the radiological diagnosis. And so at this point of time, we need to have our own DICOM app in our laptops and go ahead and interpret the images. So the first thing is when to look at the CT and when to look at the MRI of orbit. So whenever we have a case of proptosis, screening tool can be a CT scan, because orbit has a lot of fat which provides a contrasting medium, and very well-defined lesions can be easily seen on CT scan. Plus, whenever we are planning an orbitotomy surgery, we need to look at the bony anatomy. Where is the cribriform plate, where is the anterior cranial fossa, how low is the roof of the orbit, and accordingly we can plan the creating the bone window for lateral orbitotomy, and hence CT scan helps there. MRI has its own uses and we'll come to that eventually. So first we'll discuss some of the cases where CT scan has a much important role as compared to the MRI. So this is one of the classical cases that we see in our oculoplasty OPD. History of trauma, and they present with enophthalmos, limitation of movements, diplopia. And as we can see here in the right orbit, there is a fracture of the floor, and along with that there is a fracture of the zygomatico-maxillary arch complex. And we can see the inferior rectus muscle, which is at a lower position as compared to the left orbit. So this is one place where we need the CT scans exclusively, and we need it in multiple views. So bony window is extremely essential to know the exact dimensions of the bony defect, and according to that we'll be planning how big of an implant, medpore or titanium mesh or whatever, has to be arranged for the patient. And such cases we also need to look at the sagittal cuts, because we need to look at the bony ledge, that is the posterior extent of the fracture where our implant would be resting. In case, like in this case, there is an inadequate bony ledge or there is a fractured bony ledge, then we may have to screw the implant at multiple places anteriorly to keep it in proper position. Here we do have the the orbital process of palatine bone intact, which can be used to support the implant. And we can also see that the inferior rectus muscle, it is sagging, which would suggest a possible entrapment in these cases of the sheath of the inferior rectus muscle. And 3D reconstruction, again very essential, because this is what we are going to see when we open up the patient. So here we have a displaced fragment of the zygomatic arch, and there is a fracture alongside it of the lateral wall and the floor. And hence we need to plan a lateral orbitotomy with a swinging eyelid crease approach to access the floor of the orbit and have adequate exposure of the zygomatic arch as well to fix the tripod fracture as well as the orbital fractures. Next we have the other common entity, that is dermoids. Now here we can see a left internal angular dermoid, and we can see some changes, bony changes at the base of the dermoid. Comparing it with the right side, the left bone appears hyperostotic. There appears to be some form of cavitations as well. And hence, it's very essential to remove all the cavitations, and sometimes there may be communication of the dermoid across the bone, that is a dumbbell dermoid, and those need to be curated out properly to prevent recurrence. The next commonly seen case is implants. So here CT scan, I would prefer a CT scan over an MRI, because the CT scan would provide us an overview of where the implant is located as compared to the bony anatomy and the fitting. Sometimes the implant may be dislocated from its location. It may not be exactly intraconal, and the prosthesis may thus be decentered. And using imaging can help us guide further interventions for a cosmetic outcome. And finally, as ma'am had shown, lacrimal gland masses. So here it's very essential to have a CT scan along with MRI in certain cases when it may be engulfing the muscles. or the optic nerve or the orbital apex. So using a CT scan is essential because we can determine the posterior extent of our bony window creation. As we can see here in the first image, since the mass is not going into the posterior third of the orbit, a simple lateral orbitotomy with breaking of the bone at the junction of zygomatic and greater wing of sphenoid can help. And the coronal view helps us determine the anterior extent of where the incision should be placed. In certain cases, when it's too far posterior, when it's invading the posterior orbit as well, we may have to chip off the greater wing of sphenoid to access the orbital apex. Next we have cases of post-traumatic nasolacrimal duct obstructions. Here, imaging in form of CT scan is extremely essential to know the bony anatomy, the displaced fracture fragments, and the hyperostosis that has developed post-trauma. And as we can see here, there is bilateral hyperostosis with bilateral encysted mucoceles. And the bony window is also extremely essential to know the thickness of the bone, exact thickness of the bone, which may not be evident in the plain soft tissue window. And if these patients are to be planned for endonasal approach, a coronal endonasal DCR approach, the coronal scans are essential to know the exact location of the trauma fragments, the relation with the middle turbinate, and the thickness of the bone, whether it can be removed through the bone punch or we may have to use a micro drill for endonasal DCRs. And finally, we have thyroid eye disease. Inactive thyroid eye disease, when they require orbital decompression, again, CT scan is a very essential tool because we need to look at the bulk of the greater wing of sphenoid here, where we see a Mercedes-Benz sign of the zygomatic arch, greater wing of sphenoid, and the lateral wall of the middle cranial fossa, because this is the main part where the deep lateral orbitotomy is done, deep lateral orbital decompression is done. So if there is a bulk here, we can expect good correction after decompression here. And a CT scan is also essential to differentiate a muscle predominant disease from a fat predominant disease, because fat predominant disease would respond well to a fat decompression. And finally, as ma'am had shown a frontal sinus mucocele, we have a similar case. Here the bony window CT scans are essential to rule out erosion of the anterior cranial fossa. If there is an erosion, it would be a combined approach between a neurosurgeon, ENT, and an oculoplasty surgeon, as we can see in this case. And this is one of the rare cases where we had an adenocarcinoma of the nasolacrimal duct who had undergone a previous external DCR which had failed soon. And here we can see the exact extent and the bony erosions, the destruction of the middle and the inferior turbinates. And these are usually not very appreciable on the MRIs, and hence a CT scan would be much preferred in these cases. Now, when to use contrast and when not to use a contrast. So most of these cases till I have shown till now were non-contrast scans, and they provided us a very good method to determine the surgical plan. Now these are some cases where lacrimal gland masses extending into the posterior orbit, and we can see a brilliant contrast enhancement in these masses. So these are usually malignant masses because a pleomorphic adenoma usually would not enhance so much, and this patient turned out to be an adenoid cystic carcinoma of the lacrimal gland. And the other variants are the orbital soft tissue tumors, which is the rhabdomyosarcoma, and here post-contrast we can see some areas of non-enhancement which suggest necrosis inside the rhabdomyosarcoma, and the non-contrast scan shows a variegated appearance. Finally, moving on to the MRIs of the orbit. So we have T1 and T2 weighted images. The T1 weighted images are basically to look at your anatomy. So here we can see the left orbit, beautiful muscles, a beautifully delineated sclera, whereas the T2 is used to look at the pathologies. So we can see some mass in the lateral orbit abutting the lateral rectus muscle. Now further we go ahead with the STIR imaging, which is a fat suppression image, and we can see the mass remains unchanged with fat suppression. And the other we have is FLARE imaging, which is fluid suppression, and we see the mass disappears on FLARE. So this is predominantly a fluid-filled mass located inside the orbit, and it turned out to be a ciliary body cyst. Again, we have T1 and T2 weighted images, and here, sorry, T1 and T1 contrast weighted images. I'll skip this. Okay, so here we have a very characteristic appearance. On T1, we have a hyper intense mass over with a hypo intense vitreous, and on T2 we have a hypo intense mass over a hyper intense vitreous. So this is known as the yin yang sign, and it has some specificity for melanoma lesions. However, some leiomyoma lesions of the orbit also show this appearance. And here we see a huge ill-defined mass on the T1 image, not very well seen on the T2 image. But as we go for the diffusion weighted image, we see a hyper intense mass. So now diffusion weighted imaging is another important concept in MRI. This is useful when we want to look at the cellularity of the mass and compare it with the water content. So as we know, we see the vitreous as a hyper intense thing, so that is a water rich area, and we see another diffusion weighted hyper intense mass in the anterior orbit. Now, how to differentiate between a fully water filled mass versus a fully cellular mass? So there we have the absolute diffusion coefficient, ADC, which compares how much change in the MRI signal is noted over 100 milliseconds. So as the same mass, when we see on ADC map, we see vitreous to be a hyperintense mass, so it's filled with moving water molecules. But the hyperintense mass now goes hypointense. So here there are not many moving molecules, so it is supposed to be a cellular mass. So whenever we have a low ADC mass, it suggests a definite hypercellular lesion. In this case, it turned out to be an orbital lymphoma. But even benign lymphoid hyperplasia or a low-grade orbital lymphoma like mantle zone lymphoma could present in this way. And such findings warrant an immediate orbital biopsy, incision biopsy. And now here, this is the last MRI I have. We have a T1 image which shows a diffuse mass circumscribing the globe on the right side, and on the left side we have some mass in the lacrimal region. And again, on the ADC, we see, on the diffusion weighted imaging, we see enhancement in the inferior right orbit. And on ADC, we have some hypointense areas in the inferior orbit. Again, this turned out to be a lymphoma, bilateral orbital lymphoma. Now we have just brushing across orbital ultrasound. So as ma'am had already shown a similar case, orbital ultrasound is very good for venolymphatic malformations. Here we see multicystic lobulated lesions with fluid levels. So this was a hemorrhage inside the venous malformation, venolymphatic malformation. And other important places for intraocular tumors like uveal melanoma, where we see a very distinct appearance. Sometimes it may break through the retina and we can see the mushroom-like appearance of the melanomas. Now, moving on to the perfusion studies of the orbit. Here we have orbital color Doppler. So here we can analyze the central retinal artery or the ophthalmic artery mainly. And they are localized with the help of the radiologist. So this case, again, ma'am has already shared, it turned out to be an arterial malformation, and the Doppler showed a definite arterial waveform. Now we have another place where orbital perfusion studies are gaining importance, and that is thyroid eye disease, especially moderate to severe thyroid eye disease who do have some form of vision loss, progressive vision loss. So here orbital perfusion studies are extremely essential. We can see the CRA, it has very little flow and absent flow during the diastole phase of the cardiac cycle. And the ophthalmic artery again has very poor flow. These suggest orbital ischemia in addition to the thyroid eye disease, which may be leading to the visual loss. And this is the patient who underwent decompression surgery, and we can see the improvement in the orbital blood flow in the central retinal artery before and after surgery, and in the ophthalmic artery before and after surgery. So this is a new modality of investigation for thyroid eye disease where orbital perfusion can help us guide our interventions. And some surrogate markers when orbital color Doppler is not available would be OCTA macula and OCTA disc to have an indirect evaluation of what is the blood flow status for the orbit and the globe. Thank you.
Thank you, Shalin, for the wonderful and extensive